Hi, everyone. This is Vista Research Group from a kind of crazy morning. I woke up in our area without internet, and then there have been various other technical challenges. So please forgive us. Hopefully, we're moving forward now. So welcome to our Datapalooza webinar. And Stacy and I, our COO of Vista Research Group, are going to be conducting this. And I wanted to just give you an idea for how we got the idea for this webinar. A couple of months ago, Stacy made the remark that we were suddenly hearing from an awful lot of treatment centers that had outcomes data, but didn't really know what to do with it. This is progress, because when we started Vista 8 years ago, no one knew about the value of outcomes research and outcomes data, and no one was really that interested in collecting it. So it's wonderful that most centers are now doing outcomes research of one form or another. And so we thought this might be a good opportunity, since we've been analyzing outcomes research since 2016, to just present a framework for how you can analyze your outcomes data to help more patients recover and do other things like comply with the Joint Commission or CARF, or motivate your staff, negotiate with payers, and so forth. So Stacy and I are going to be presenting today. And here's an agenda of what we're going to go over. We're trying to provide you with a framework for how to start analyzing your outcomes data. And the most important question for you to answer is, how effectively are you helping your patients recover? So we'll go over the key questions there and how you might use those analyses. And then we'll segue into other analyses that can help you identify key opportunities for improvement. And then we'll spend the majority of our time talking about how to use your results to negotiate with payers, comply with CARF or the Joint Commission, motivate and retain your staff, or attract more patients. And hopefully we're going to have some time at the end for Q&As. I'd ask you, as we go along, if you have questions, put them in the chat, and we'll try and answer the quick ones, and we'll save the ones that we think would be of value to everyone so that we can ask them at the end. So
And Joanna, I'm sorry to interrupt. I'm hearing that the chat's not disabled.
I just turned it on.
Perfect. Thank you so much.
Okay. So the key question we recommend you use your outcomes research for is to answer, how effectively are you helping your patients recover? I think there are really three key questions that you want to answer during treatment. The first is, are your patients completing treatment? Are a high percentage of them successfully completing all your recommended treatment? Because if they're not, it's not that likely that they're going to be able to recover afterwards. The second question is, have their co-occurring disorders and any other underlying issues that are affecting their addiction or their mental health, have they improved during treatment? And then third, are patients satisfied with the treatment they received? But there's a fourth question that I think is the most important of all, because it pulls everything together. And that is, when we contact your patients after treatment, 1, 6, or 12 months after treatment, are they achieving their treatment goals? Are they achieving long-term recovery? So we're going to talk about each of those four areas, four questions in order. So the first question is, are your patients completing treatment? So I presume that everyone on this call, and by the way, we have an interesting mix of Vista clients and non-Vista clients. So we're going to use Vista's results as examples, but we're also going to provide information for non-Vista clients on how to do these analyses too. So I presume that pretty much everyone has information about what percentage of your patients are successfully completing treatment versus leaving AMA. So if we look at this result, we're going to pretend to be Apollo Recovery Center. It looks pretty good. 57% of your patients are completing all recommended treatment, and some more are completing a level of care or detox. You know, close to 2/3 are probably completing at least one level of care. 21% are leaving AMA. If I just look at this by itself, I think not bad. You know, it looks like we're doing pretty well. But what we've learned is that the key focus, you really don't know how well your treatment center is doing until you compare your results to the norms of similar treatment centers. So to really understand how effective you are doing at keeping patients in treatment, you really need to compare your reasons for discharge to those of a group of similar treatment centers. Down below, what we've shown is the discharge reasons for all adult SUD patients that have been discharged in the last couple of years. And if you compare the two charts, what you see is that at Apollo, 21% of the patients left AMA versus at Vista overall, only 16% left AMA. So it looks like we have a higher AMA rate, and not surprisingly, we have a lower percentage of patients who are completing all recommended treatment. So while if you just look at the first graph, you think, yay, you're doing pretty well. If you look at the second graph and compare it, you can say, gosh, there really is an opportunity for improvement here. So a second question we ask is, have patients' co-occurring disorders and underlying issues improved? So there's a number of different issues that you may be considering. The most common that pretty much all of our treatment centers monitor is whether patients are coming into treatment with depression, anxiety, trauma, suicidal thoughts or behaviors, eating disorders. A lot of our treatment centers also monitor things like mania and psychosis, particularly our behavioral centers. Mostly our adolescent centers find it necessary to pay very strong attention to self-harming behaviors, and some of our other centers too. And then severe mental health centers probably will pay attention to daily functioning. So I'm going to use depression as an example, since essentially everyone monitors their patients with depression. And what we feel is the easiest way to compare your results is to create a chart like this, where you look at what percentage of your patients at the start of treatment have a PHQ-9 chart, that or assessment score that indicates they have moderate to severe depression. And then how has that reduced by the time they leave treatment? So here, what you can see is 67% of your patients came into treatment with moderate to severe depression. By the time they left treatment, it had dropped to 12%. Again, this looks incredible, is it? Well, the best comparison is to look at the same norm for other adult SUD centers. And in fact, what we can see is that is impressive. At Apollo, we had slightly higher percentage of patients coming in with moderate to severe depression, and yet we were able to drop by the end of treatment to where only 12% had moderate to severe depression symptoms. So we're doing well. But that doesn't mean, since 12% is the average, that doesn't mean that there's no room for improvement. Certainly, some centers have even lower numbers than that. So a third question we'll look at is, are patients satisfied with treatment? And here there's really two different questions I'll ask. One is just a general satisfaction with treatment. And what we can see is Apollo's very satisfied rate is 76% of patients saying they're very satisfied. So Apollo patients are very pleased with the treatment they're receiving. And that's substantially higher than the norm of 71%. And then the other thing we'll look at is very plus somewhat satisfied. Frankly, I pay a lot more attention to the very satisfied. I think that varies a lot more, but it is, valid to also look at what percentage are very or somewhat satisfied. So if I look at this issue, if I compare Apollo's results at the top to the norms, it looks like Apollo is doing a good job satisfying its patients. And another question that I recommend asking is, were your patients' treatment goals met? Now, this is a question that the Joint Commission requires of its accredited organizations. And what we do is we'll ask this on any last survey that patients submit. And so again, if we compare Apollo's results to Vista's norms, Apollo is doing a better than average job of meeting treatment goals. And so the fourth question, and the one that I personally think is most important, is, are your patients achieving long-term recovery? And so Vista follows up with patients 1, 6, and 12 months post-treatment. We'll make 10 to 15 attempts to contact the patients each time, and we pay them a little bit to take the surveys. We also reach out to moms and spouses that the patients have given us permission to contact in case their cell phone number no longer works or something like that. And so what you can see here is Apollo was able to contact 22% of patients who said they had been completely abstinent since the time they left treatment 1 year before, and another 18% who said, well, yes, I did have a relapse earlier, but I've been able to regain active recovery, and now 40%, and now have been meeting my abstinence goals for at least the last 30 days. So that those two combined, the percentage of patients who are meeting their treatment goals in the last 30 days is 40% for Apollo compared to 36% for Vista's norm. So again, it looks like Apollo is doing a good job at helping patients recover. So the next thing I want to cover is, how can you find or create these analyses? So for Vista's clients, what we want to do is go to Vista, go to our test drive, and I want to just show you the information that that Vista clients will see about their patients. Because we do an extensive monitoring of patients at the start of treatment, we screen them for a variety of different co-occurring disorders, and then we monitor them throughout the time they're in treatment. Vista clients see a patient dashboard like this with all the different things that we're monitoring them during treatment. So the black bar on the left is how the patient reported feeling in the 30 days before they came to treatment. So patient Jason, and by the way, this is all, of course, fake data. Jason came into treatment reporting being very severely depressed. He's been doing a lot better with depression, but something just caused his level of depression symptoms to spike. And you can see we're monitoring him for a number of different co-occurring disorders, eating disorders, suicidality, cravings, whether he's used drugs or alcohol, whether he was taking all of his prescribed medication. You can monitor different things depending upon your organization's needs. We always ask satisfaction with treatment, and we also ask some open-ended questions. And everything the patient tells us, we immediately report back to the clinical team. And what we hear from our clinical users is oftentimes the comments are even more useful than other things, because people oftentimes will admit things to the anonymous internet that they may not be comfortable admitting face-to-face. Another thing that we provide to all of our clients is information about what brought each patient to treatment, what are they in treatment for, how much were they using, what else were they using, how long have they been using their primary drug of choice problematically, how severe is their addiction, what brought them to treatment, what are their treatment goals, both drug and alcohol related and non-alcohol related. information about previous treatment episodes, demographics, social determinants of health, health status, and so forth. So all of this information is instantly available for our about each patient in the software. But what I really wanted to focus on today is where Vista clients can find this type of information, and that is in the data analytics platform. And Vista's data analytics platform reports about 65 different patient-reported metrics, and you can look up each of them. Whoops, I didn't mean to do that. Let me Among everything else, my mouse stopped working, so I'm trying to do this with a pad that I'm not that used to using. Let's see, let's get down here. Okay, back to analytics. Don't you love technology? It's great when it works, and unfortunately, it doesn't always. This has been one of those days for us. So Vista's data analytics platform is updated every night. And as I said, it allows you to look at 65 different patient-reported metrics, and you can look at all of them by location, different levels of care or different treatment locations, by different payers. You can look at them by different clinicians. You can look at them by different periods of time. So it's very useful as you want to dig into your data. And how you look at the patient progress is, well, here's the depression chart that I showed you just a minute ago. You can see those improvements in symptoms between the intake and the last treatment episode for all the different co-occurring disorders. You can see improvement in suicidality and eating disorders. On the completion tab, you can see the reason for discharge table I presented, patient satisfaction, were their treatment goals met, were they using medication on their last survey, what's the median length of stay of patients. You can look at primary drug of choice and how it's maybe differing by location or a level of care. You can see how severe are the addictions of your patients, how motivated are they to meet their drug and alcohol goals, what medications are they coming into treatment using. You can also look up general demographics. So oops, again, I'm not used to using this. So you can look up age, gender, what brought them to treatment, were they living in a stable living environment or not, were they working or going to school, where in the country did your patients come from. And then you can also look up one more interesting thing during treatment, and that's patient comments. And again, you can, in this case, you can actually look up patient comments by the satisfaction level that the patient had. So if you're noticing that satisfaction with treatment is dropping at one of your locations, you could look and see what are the comments that patients are making who are somewhat dissatisfied with treatment, and maybe see if you can nip any of these issues in the bud. The last thing that you can see is top lines of your outcomes results. So you can see, and this is updated just on a monthly basis, what percentage of your patients were reachable and said they were meeting their treatment goals at 1, 6, and 12 months post-treatment. So here's the information that Vista does provide to its clients. Another thing that Vista provides is very comprehensive during treatment and post-treatment outcomes reports. So you can see that once a year you get very detailed reports that do a lot of these comparisons to norms and provide trend data and the other things I'm going to talk about in a minute, so that at least once a year you have a very easy way to look overall at all of your results, both during treatment and post-treatment, and use them to determine some potential areas for improvement. So I suspect that probably everyone on this call is collecting information on discharge reasons. Whoops, I went backwards. Discharge reasons and patient satisfaction based on, the discussions I've had with centers over the years. It seems like most centers are collecting this information. So you should be able to start there. You may or may not be collecting information on treatment goals. Even though this is a Joint Commission requirement, I'm not sure that all Joint Commission accredited organizations are collecting that. But if you are Joint Commission accredited and you're not collecting it, I'd strongly suggest that you start. You probably are collecting some of the data on one or more of your co-occurring disorders during treatment and the improvement over time. You may have that in a gigantic spreadsheet of PHQ-9 scores that have come in at different times for different patients. And so to help you analyze, if that's what you're looking at is a massive spreadsheet and you just don't know, how do I turn it into a cute little chart like this? We're creating a video that's demonstrating how to create this graph in Excel. I had every intention of doing it this morning. Without internet and everything else, I had other problems. It will be loaded here by the end of the day today. So if this is something that you're interested in help figuring out how to do, I'll create a little 5-minute video that walks you through how to create that from your own spreadsheet of data. What you're probably not collecting if you're not a Vista client is post-treatment outcomes data from a substantial percentage of your patients. I know a lot of people are doing outcomes research where they're sending out an email or two. It's extremely hard to get responses from more than a tiny fraction of your patients if that's what you do. 10%, 15%, maybe if you work really hard, 20%. But the problem is those 20% are not representative of your entire patient population. And so this is probably something, if you're not using Vista and are not interested in, this is probably something that you will not have at this point. So because it's so important to compare your results to norms, we've created 3 sets of norms for Vista Research Network that we have uploaded on these pages. So highly recommend, if you are working with SUD patients, that you go to Vista Research Group's page, addiction-treatment-norms, and you can download the norms for adult patients and for adolescent patients attending SUD treatment. If you're providing behavioral treatment, recommend that you go to the page behavioral-treatment-norms, and you can download the norms data for adult patients attending behavioral treatment centers. We have some adolescent behavioral centers, but we don't have enough data yet that we're comfortable providing norms for those. We will be doing that in 6 months or a year. And I want to call out Jen Coppola, who spent the last couple of weeks creating all of these norms. She's done a fantastic job. It's a lot of work. Okay, so now from this basic framework, let's use it to identify key opportunities for improvement. So the first question I would ask is, did the earlier comparisons to norms identify any areas where other centers are doing better than your center? And of course, we noticed that other areas were doing a better job of having their patients fully complete treatment. A second question you can look at is, are your results getting worse over time in any areas? And what we provide in our reports are trend data. So here you can see that at Apollo, in the top graph, in 2020, only 13% of patients were leaving AMA. In 2021, 15% were. In 2022, 18% were. So this just reinforces that AMAs would be a very good place to focus on trying to reduce. Another thing you might want to look at as you're trying to figure out what areas to focus on and where to focus on them, what programs and so forth to start with, is, are your results worse in one or more of your levels of care or locations? And so what's interesting, this is, we can look at Apollo, and what you see is their residential and their IOP programs both had about 16% of the patients who left from that level of care left AMA. But look at PHP, it's 30%. Now remember, again, this is fake data, okay? But you may see something similar when you look at your own results. And so if I was Apollo's CEO or clinical director, I would start to focus on what's going on in PHP that is causing so many people to leave and being asked to leave. The terminated number at 14% is also extremely high. And then finally, another thing that you can look at is, do your results vary substantially by clinician? What this shows is, again, fake data, but it is based on real clinicians. We had real clinicians' data that we put in here, and I was shocked to see how big a variation there can be in AMA rate by clinician. Hopefully you won't find anything this dramatic, but you might if you do the analysis. And again, this is an analysis that we include in our progress monitoring reports. So I've now given you several places to look to start thinking, what are the 1, 2, 3 areas you really want to focus on improving? The last question, once you say, I think it's AMAs, or I think, it's this and this. The last thing, just make sure that the areas you choose to focus on are really going to have a big impact on patient recovery. And what we can show, if we were to pick AMAs, for example, is that whether a patient completes treatment or not does have a huge impact on their likelihood to recover. So among Vista's SUD programs that are predominantly abstinence-based, among the patients who successfully completed treatment, 41% of them were reachable and said they were meeting their abstinence goals for at least the last 30 days at 1 year post-treatment. That 41% compares to only 27% of the patients who didn't complete recommended treatment. Okay, now we're going to jump into how can you use your results. The first thing I want to talk about is how to use your results to negotiate with payers. And there's several things that we collect from patients and report back to you that might be really useful. This is the difference in expensive medical interventions between the pre-treatment year and the post-treatment year. So in the year before patients came to treatment, 51% of them were in the ER at least once, and a good percentage of those were in there 2 or more times. By the year after they had left treatment, it had dropped almost in half to 28%. And we see a similar reduction in unplanned hospital stays and detox treatments. So hopefully this savings alone is enough to cover the cost of your treatment. And you can use this chart to argue that you deserve a higher reimbursement rate or pay for performance bonus or what have you. Another thing that is really important to payers is your readmission rate. And what we can report for you is the percentage of patients who readmitted to your center within 90 days and how that compares to the Vista norm. Of course, they may have readmitted someplace else. They may have gone someplace else, and we do not have that data. But this will give you a hint that your readmission rate is looking better than average. So now I'm going to turn it over to Stacy, who's going to talk about how to use your results to comply with CARF and the Joint Commission, and also to motivate and retain your staff. And I will stop sharing so that Stacy can share.
There we go. All righty. So let me go ahead and put this in presentation mode. All righty. So I am going to, as Joanna said, focus on using the data for accreditation purposes, and then later talk about how to use it with your clinical staff. And my background is as a clinician by training. I'm a licensed clinical social worker. And while working for Vista, I also have a small private practice that I do use the software in. It's brought great benefits. I had fun thinking through that while I created these slides. So for the purposes of accreditation, we're going to focus on our clients primarily are either accredited by CARF or Joint Commission. So we're going to focus on those two, knowing that there might be some folks out there that are accredited by other organizations. You still might find this meaningful because they're all trying to do the same thing, which is help organizations create and meet a standard for care, and sort of have that be standardized in some ways, allowing for diversity for treatment populations in that framework. So just to orient us, I'm going to start with CARF, but I thought it would be useful to look at the two organizations. And I know there's a few treatment centers that are accredited by both, and they have a little slight different bend on using this type of behavioral data for the purposes of accreditation. So for CARF, they are really interested in looking at success. So both at the individual patient level, the number and criteria created and the process created for assessing how successful a program is at implementing their program and having people move through the program successfully. CARF also looks at success in the same way in their aggregate data. So we're going to get into that. Joint Commission has a little different standard. It's more prescribed as far as using behavioral self-reported data. And so they really look at it on the individual level, using it to inform clinical care. And then on the more macro level, aggregate data, they're looking at your data analysis process. So are you using the data collected from patients, looking at it from a macro level scale to see and make meaning of what's happening. So to look at it and decide what that means for your organization. So starting with CARF, they focus a lot on process, documentation, and implementation, and they use a lot of terms related to performance measures. They also, in their own literature, talk about how much these following words are used: the policy around a particular metric or performance measure, the plan for how it's implemented and collected, how you document it, and the documentation that goes with it, and also where it's written. So mainly making performance measures concrete. So with CARF, first you want to pick a metric that articulates, of course, performance. And I brainstormed some options. So decreased negative symptoms. So in a patient population, how well are you decreasing negative symptoms? Like how well are you decreasing depressive symptoms, so on and so forth. How well are you increasing coping mechanisms and ability to manage situations and feelings and mental health issues? So how well are they being prepared to manage and go into a maintenance phase? How the patient feels as a result of treatment. And also you want to pick something that you can easily aggregate across programs. So they think about program. So you might have different measures for different types of programs, and across each program, are you able to take data and aggregate it across all those programs? You have it, you can look at everybody to get information about it. For our purposes, I'm going to use the Columbia Suicide Severity Rating Scale just to get you through an example of how I might use this particular scale to create a performance measure for CARF. So first, I'm going to select a criteria that indicates how well you're serving your patients. I would define the population. So who are we talking about? Some treatment centers I know that we've worked with look at only people who've successfully completed treatment, so that they go through all recommended treatment and how are those folks doing is one way. Or some places look at all patients. So no matter how they discharge, or being a little bit more broad about how they might have left the treatment center, or what their process was, what's their scores. Then you want to select a score that indicates success. So for example, for the Columbia scale, it might be you want to look at patients who have no suicidal ideation. So they would score a 0. 2 questions, and they would say, no, I don't have any ideation at this time. Or some places also look at the rate of change. So for example, if they have a 4 or above on the scale, which indicates that they are preparing to act or thinking about acting, you want to decrease that down to no action, just thoughts, for example. So that might be another way that you could frame success. You also want to think about the timing of the assessment. So what are you comparing? What are you sort of looking at as far as time? So saying one example could be looking at intake versus discharge. So how are they feeling at intake and how does that differ at discharge? So I'll take you through this graph. So this is another one of our charts from our data analytics, and we're using Apollo again. And at the top, there's a little in parentheses, you'll see our base size, so the number of patients that we're talking about at Apollo. And I have at the top here of the 1,191 patients who submitted an intake survey and successfully discharged from Apollo. 80% of them reported no suicidal thoughts or intentions prior to discharge. So in this case, we're assuming, and this is sort of the metric I might use, this is what I would say to Carf, that this is a metric I'm going to use and measure to sort of inform our success with patients. And so because I'm going to show you a couple of charts to how I get here, but this chart is showing you at intake how people reported. So at intake of these almost 1,200 patients, you can see at the bottom, we're going to focus on that bottom one, which is the score of 1 on the Columbia Suicide Scale, saying they wish that they were dead or could go to sleep and not wake up. So what I did here, I think I have, I think I might have the wrong picture here, but I'm going to explain what I did here just to save time. Might pop up the next slide, but either way, the chart should indicate the change over time. So actually the next chart, hopefully it's next slide. If not, I'll make sure to update that before we share out this PowerPoint. Actually, it had that of the patients who completed the survey. So we had 149 patients who completed an update survey on our base size. So this chart, next chart that maybe is showing up would show you that. And of those 1,000 or so patients, only 9% of them reported having suicidal thoughts and intentions. So what I did is I just basically said, okay, it's 9% of those. So I did a little math here to sort of take out the folks who didn't update the survey, take that into account because we had a little over 100 folks who didn't actually take an update survey, but I'm still reporting on those folks. So I did a little math to show that 80% of all patients with the intake survey did say that they were not experiencing symptoms. So we have to take the data, and this is something I encourage our clients to do, is the numbers are there for us to play with. So while sometimes the chart doesn't say exactly what we want, the data is there. And so you can do little math. I'm a social worker, not a statistician, so I was able to quickly do the math to say of all of the almost 1,200 patients, 80% did not report those symptoms. So moving on to Joint Commission, there's a little bit more prescribed. So Joint Commission requires behavioral health organizations to assess outcomes for the individuals that they serve through standardized tools or instruments. So first, you got to have a standardized tool to use. Next, you have to take that tool, use it to collect data, and generate, use that reporting generated to inform the patient goals and objectives. And then lastly, they want you to take a cross-section of all that data. So take all the data collecting from patients, aggregate it out, and look at it to see what you might make meaning of as far as your patient population. So first, talk about the standardized tool. I'm using the Columbia Suicide Scale again. They want to see a tool that's patient reported, has the ability to implement across programs. So you want to make sure that your tool is not so niche that it only assesses a certain population of your patients. You want to have it be broad enough that you can get it can be applicable across all of your patients participating in the program. It needs to be sensitive to change. So that means it must be able to track improvement or regression. So it needs to be able, you can administer it over and over again to see the difference and change over time. And lastly, it needs to be administered during the treatment process. So it needs to be something that you can collect while they're in treatment, so that way you can use it to inform the clinical care. They don't specify what tool you need to use. They have several examples on their literature and on their website. Columbia Scale is one of those examples. And they don't also tell you how often. They just say it needs to be done during treatment, often enough that it can be used to inform clinical care. So you have some flexibility about scale and timing. So after we do the standardized tool, you also have to use the data to analyze it and inform patient care. So I have here a couple of goals that I made from this person. I believe their name, I'm forgetting their name. I think it's Chelsea maybe, or something along those lines. I'm forgetting the name of the patient I chose from our data analytics, but from our test drive site. But either way, so what I chose is a standard goal for suicidality. And we want to alleviate the suicidal ideation and help them return to their previous level of functioning, their highest level. And the objective I have is that we want to state the strength of suicidal feelings. That's what we're doing here with the Columbia Scale, the frequency, and the details of plan. And so you want to also be able to use, these tools are not meant to be used in a silo. They are supposed to come along with clinical impressions. And so using this to then be able to ask further questions to the patient about their suicidality is how you get to the meeting of those objectives. Lastly, with analyzing the data for informing patient care, what we hear a lot, and even for a treatment center that I'm on the board for in my town here in California, what people tend to get dinged on is not seeing it in the progress note. We have heard that having the actual reporting tool, so whether it's a paper report or whether it's a chart exhibiting symptoms, having that in the EHR is very helpful. But also here, being able to write in the progress note what's happening, write it down. So as we can see with this particular patient, they've had some ups and downs with their suicidality, but right now they're hovering right around a 2, which means they're having thoughts, but they're not engaging in any planning. And so that's why I put in the progress note, I indicated the date of the score and what the score was. I described what the score means. And then I also said that they did, and very important for suicidality, but they denied planning or any action. And I also put that how it's changed since the previous score. So that's kind of what you might want to write in your note. Last, we're going to go on to talk about this concept of looking at it in aggregate. And I'm going to take a sip of water because my voice is going. So here I have suicidality data for Apollo Treatment Center with a year-over-year look to see what we've had as far as change over time. So on the far left here, all the different questions for the Columbia Scale. And then on the little further in here, my cursor is, you can see the data for 2020. It goes on to 2021 and 2022. And what we can see is that actually their data has stayed relatively stable, with the exception maybe of 2022. There's a smaller dip, but perhaps not enough to say that it's mostly remained stable over time. You can decide to make what that means for your treatment center. So for Apollo, we can decide if that's good that it's staying stable based on our client population, or if it means, oh, wait, we want to sort of be able to move that 9% down a little further. They don't prescribe how you aggregate this data or what meaning you make. They just want you to be engaged in a process, have that process articulated in your process documents, and be able to articulate that to them, and then follow that process on an ongoing basis. So this could be quarterly, for example, or something like that. So lastly, I'll talk about using data with staff. There are 3 areas that I thought of, and there's probably more that we could discuss, but I'll focus on these 3 for today. First is supervision. Next is needs for training or continuing education. And lastly, and my favorite, celebrating success. So for supervision, one way is you can use the data. And here we have, I'm using the Columbia Scale again, but I'm looking at actually what we have in our software. It's called a summary report. And what it allows us to do is look at a whole clinician's dashboard. So this is a clinician, the same clinician we've been looking at, their dashboard, and all these little dots down here are representative of patients. And in our software, if they are in, for some of the scoring, it's yellow for moderate, and for other scoring, it's red. And for the Columbia scale, we have it at no symptoms and all symptoms being a red here for saying that it's important to look at. So we label patients who are in the yellow for those moderate symptom reporting mechanisms, but for here, we just have all red because it's suicidality. So we have one patient here, Connor, who's in the red. So if there were more patients that were in the red, or if you're looking at depression or anxiety, you might see more dots that are labeled because they have higher symptoms. This allows you to look at the clinician's caseload. So you can do this with any of your data and just sort of look at their data overall to see if there are patients you want to focus on for supervision, to identify patients that might be difficult for them to treat, especially for folks who are limited license or associate therapists. This can be very helpful for getting a nice snapshot and looking at the data from a snapshot angle to talk about their caseload. Also identifying strengths and areas for growth for clinicians. So on this chart at the top here, I have Georgia. We can sort by clinician in our data analytics. And so I sorted for Georgia, the clinician that's treating Connor and others. And what we have here is on the right or the left sidebar here is indicating what the intake scores were for patients. And then the right sidebar is indicating scores at the last survey reported by those patients. And we're only looking at here patients who did have an update survey, much like the Columbia scale. So we're looking at people who did update their survey. How are they feeling at their last survey report? And we're comparing that to down here at the bottom, Apollo Treatment Center's overall rates for trauma. So they're both trauma charts. And as we can see, Georgia has a lower percentage of her patients experiencing trauma at their last reported survey as compared to the last treatment episode for all patients across Apollo. So again, this is where you can make meaning as a supervisor of what this might mean for Georgia. Could be that she has a different caseload that's might explain the difference. Could be that Georgia has a strength in treating trauma. In that case, you can decide what to do with that. It might mean that if Georgia is sort of I think about associate therapists I work with, if I'm seeing an area where I'm like, you really seem to both be good at this and seem to be really interested in it and fulfilled by it, we want to give Georgia more training to have her maybe specialize in that. It could go the other way too. If we're seeing scores that look flip-flop, where the scores for a clinician are looking a little worse than what the average is, or what we're seeing across the whole treatment center. You might say, okay, let's think about that. Is it, again, a caseload issue? They're just getting more of those types of patients? Or is there an area where there could be a little more education? That it's just giving you data to use as a supervisor. Looking at persistent symptoms. So identifying, going off of that sort of education and training piece, continuing on with that. So looking at persistent or new symptoms in a population. So again, I have some charts here looking at trauma at Apollo Treatment Center. The top chart is comparing Apollo to Vista's norms, so using benchmarking of patients that are centers that are similar to Apollo. And the bottom here is looking at Apollo's patient progress over time again. So we can use this data to, again, make meaning. So we see here that Apollo has higher percentages of people feeling trauma symptoms that are moderate or probable to severe trauma symptoms at last survey before discharge. So the last survey before treatment at the end of the treatment episode. And then also here we're seeing an increase of trauma symptoms year over year at that last treatment episode survey. And so that you can use to sort of make meaning of, what does that mean? What do we need to do with that? Lastly, we can talk about for training, different skill protocols. So this is our AMA chart. I think Joanna may have showed it earlier for Apollo Treatment Center. We can make lots of interesting guesses about what's going on here. But here are some that just kind of came up with as possible training opportunities. If we have clients that have difficulty with relationships or connection as a part of our population, it could be that rapport building and training on how to do that with clients who struggle to connect could be something that we could train on. We could also look at this AMA rate here, and I'm going to explain a little bit what this chart means before I keep going. So the blue here indicates folks for each. So let me actually start on the left side. These are clinicians, once again, oopsie, oh no, I clicked too many times. There we go. And don't allow, there we go. So we have the clinicians' names over here that are at Apollo. And for each clinician, we're looking at people who successfully completed treatment. So for example, Tracy has 92% of her patients successfully completing. And on the red, who AMA'd. The white is other reasons for discharge. And so we see here that Tracy doesn't have any clients who AMA'd. So lots of reasons why that could be for Tracy, or why Karen has more AMAs than other folks. But either way, you can sort of look at that and make some inferences or hypotheses. One that I came up with is figuring out whether patients are appropriate for treatment here. So sometimes it's a mechanism of intake processes. Who's appropriate for treatment? I know a lot of places use the ASAM criteria to figure that out and to figure out where to sort of draw the lines, when to refer out. That could be an area of training as well. Lastly, I will talk about celebrating success. So these are some comments that are based on real comments that we get in surveys. And so I just want to highlight these. I'm sober today and would not be able to do without you guys for Apollo Treatment Center. The last one really gets me though. They care very much about my recovery and me as a person. So when someone feels so connected that they really feel like this place cares what happens to me, is one of the best affirmations I can get as a therapist. So celebrating those wins, celebrating with your clinicians how well they're doing can be a great way to use the data as well. I'm going to stop sharing and pass it off. I think Joanna has a couple more things to share. And then hopefully we'll have time for questions.
Okay, I'm going to share my screen again, and whoops. I am going to, whoops. I'm going to actually stop sharing for a second. I have to jump ahead. Okay, there's only one last thing that, oops. So one last thing that we wanted to cover, and that is how to use your outcomes results to attract more patients. And this is my favorite thing because it fills in and explains why I got involved in this work in the first place. So any of you who know my story, I had a daughter who was a very serious alcoholic, and she was in and out of treatment for multiple years. And I kept getting so upset that I was forced to make decisions on where to send her for treatment on the basis of who was nice on the phone instead of who provided effective care. So once you have post-treatment outcomes that you're happy with, you can start to promote them on Conquer Addiction, which is a nonprofit site that my daughter and I created a couple of years ago. If someone is looking for treatment, they will come to the site and they can choose a lot of different options. We'll just show California. They could choose, I need treatment for an adult or an adolescent. I need this level of care. I need these special programs. I don't know why that's not pulling down. These payment options. There we go. Okay, so maybe they want faith-based, they want 12-step or not 12-step, what have you. So you enter what type of treatment you're looking for, and you will get a list of treatment centers that meet your criteria, with those with the best independently validated outcomes at the top of the list. Now, you do not need to use Vista Research Group, of course, to submit outcomes. You just need to be following the research protocol that has been set up by the independent Conquer Addiction judges. So if somebody is interested in learning more about your center, they can come to your page. They can see your website, maybe a video, your admission line number, and they can see the actual research results that justified the 5-star or 4-star rating. And they can see that for Avery Lane, after 77 days, 54% of their patients were reachable and abstinent for at least the last 30 days at 1 year post-treatment. And they can also see the impact that treatment had on the patients, on how they were feeling, the difference between intake and 1 year later, on how they were feeling overall, how they're getting along with their family, et cetera, et cetera. It costs $199 a year to have a page on conquer addiction. That we're not doing this to, to make money. This is our way to give back to the industry that saved my daughter's life, and that hopefully is saving. We want to help other families coming behind us to also find really effective treatment. So we've got a grand total of 3 minutes left. If you have any other questions, I know we had one question that came in, which I'll answer, and that is, what do we consider statistical significance? But what in our data, what is statistically significant? If you have other questions, please ask them now so we can answer. So Cindy, we focus on statistical significance when we're reporting results out for the industry as a whole. Like, we recently reported what are the 10 factors that make a difference in whether someone is able to recover. And there are things like, how long do they stay in treatment? What's their primary drug of choice? Some interesting things like whether they're a smoker and what their trauma symptoms were at discharge. There, when we make claims about the industry as a whole, we do make sure that the things we're talking about are statistically significant. But, you asked about, is 79 to 81%, is that statistically significant? Well, it depends, right? And it depends on how large a base size do you have. If you're looking at 79 to 81% difference for 100 patients, no, that's not statistically significant. That's probably a wash. If you're looking at it for 1,000 or 10,000 patients, that probably is statistically significant. So we focus on how do we communicate the research results in a very simple, easy to understand way, without getting into all the impact of all the questions about statistical significance. Because we just want our clients to be able to use the results to understand the results and use the results to make wise decisions. So did any other questions come in? Anyone want to raise their hand and ask a question? Well, anyway, we will send out an email later today with a link to the pages for the norms, and also to the little video that we're going to create to show you how to create your own little co-occurring disorder charts to everyone who attended today. And if you have any other questions afterwards, please don't hesitate to reach out to Stacy or I. I thank you so much for joining us.